Welcome to this recording of the Cheshire Merseyside Cancer Alliance Primary Care webinar, which took place in May. My name is Debbie Harvey and I'm the Primary Care Lead at the Alliance. Just to remind people that at the time of recording, there are still places left at the Red Whale events across June, which are taking place in 3 different geographical areas across Cheshire, Merseyside. We would encourage people to register for these events, which are currently open to any clinicians involved in referring people for suspected cancer and also for trainees. The aims of this session are to explain what we are doing as a Cancer Alliance in response to the National Planning Guidance, provide an overview of the requirements of QOF, the PCN-IIF and PCN-DES, and to provide you with some ideas and signpost you to available resources. First of all, we're going to go through some data. With regards to prevalence of cancer, there are over 2.6 million people registered with GP practices in Cheshire, Merseyside, and in 2020, over 100,000 people were affected. The proportion of women, as you can see, was greater than men. Looking at mortality in 2020, there were 7,000 deaths due to cancer, and this is greater than the England average. Looking at incidence, over 16,000 new cancer diagnoses were made in 2019. And again, this is higher than the England average. In 2023, nearly 160,000 patients were referred to cancer services by GPs or through the national screening programmes. And we know also that almost 17,500 patients received a first treatment for cancer, again including GP referrals and patients from the national screening programmes. So if we look at the Alliance, the Cancer Alliance has a number of roles. It's responsible for leading improvements in cancer performance, quality and outcomes across the system, and for delivering a comprehensive transformational work programme to deliver the cancer ambitions set out in the NHS long-term plan and in the 24-25 operational planning guidance. We are hosted as an organisation by the Clatterbridge Cancer Centre. We report to the National Cancer Team and are effectively the cancer arm of the ICB. We work across the system to support increased rates of early cancer diagnosis, including innovation. We look to improve performance against waiting time targets. We also look at long-term sustainability of cancer services, and also look at reducing unwarranted variation across the system for our patients. What are we all trying to do collectively? Well, we have this ambition that by 2028, 75% of all cancers will be diagnosed at stages 1 or 2. And we look at early diagnosis in Cheshire and Merseyside. This data is from 2020. We can see that there are still a number of tumours on the left-hand side of the graph where staging happens a lot later, and those patients will have poor outcomes. On the right-hand side, we can see that breast and skin fare much better. So there are 7 programmes in the Alliance which interface with each other to varying degrees. And you can see that we have a primary care programme, which is really important and is not universal across cancer alliances. And we interface with a lot of the other programmes and projects that you can see across this slide. What have we been tasked to do with respect to primary care and cancer in 24-25? So we've been asked to look at improving referral practice for bowel, lung and one other tumour site. We've been asked to obtain local insights and input into the development of resources to implement local incentive schemes for primary care in 25-26. We have also been asked to ensure that those patients who are at low risk of lung cancer, especially non-smokers, but who present with possible symptoms, are consistently offered a chest X-ray as the first diagnostic, and if that is normal but symptoms persist, that further assessment is pursued as per smokers and higher risk patients. We also have been asked to strengthen the ways of working between primary and secondary care, including developing mechanisms which enable feedback on referrals and drive improvements in referral quality. And lastly, we have also been asked to support PCNs to focus on communities of high deprivation. We've also been asked to look at screening and HPV vaccinations. So with breast screening, there are inequalities in uptake for breast screening, which continue to be lower than pre-pandemic levels, particularly in those being invited for the first time. In bowel screening, though, overall uptake has increased with the introduction of FIT, but there are inequalities, particularly in the younger cohorts, which are now included in the staggered age extension. And for Cheshire and Merseyside, that includes people who are 54, 56 and 58. With cervical screening, the overall coverage has continued to fall in the past 12 months, and there is a need to improve coverage and access, particularly in lower uptake areas where access may be a barrier. With HPV vaccinations, the national uptake ambition is 90%, but we fall way short of that. And in fact, the numbers have not increased since the pandemic. There is a focus on catch-up, looking at women up to the age of 25 and men who have sex with men up to the age of 45. And that will help contribute to the NHS's aim to eliminate cervical cancer by 2040 and should support the prevention of other cancers, including head and neck. So if we look at some of the projects that we are involved with, we are working on audits of bowel, lung, head and neck and gynae, and plan to work with secondary care to undertake audits into the completeness and NICE compliance of referrals for urgent suspected cancer. The audits will also support our evaluation of the new forms that are out in the system and assess the response of secondary care to incomplete or suboptimal referrals, which are referred to as rejections and return to referrer, and the mechanisms by which these are being managed. We have a big focus on education this year. As I mentioned before, we had red whale cancer updates in June, and at the time of recording, we have a lung cancer webinar in 2 weeks, which will also be recorded, and a number of other webinars happening across the year. We are also developing a data dashboard. So recognising that it's very hard for primary care to see all cancer data in one place and indeed have access to this data. So the dashboard that we are developing is based on the South East London dashboard, and you can see a screenshot of this on the right hand side. So phase 1 will focus on screening, and that will have granular information drilling down to practices, and that will be cross-referenced with demographic detail and geospatial mapping. Webinars will take place later in the year to support dashboard navigation, and there will also be focused engagement in those areas which may need more support. In phase 2, which is planned for the end of this year and 2025, the dashboard will start to include FIT testing, referral quality, targeted lung health checks, teledermatology, and many other. We also have GP place-based leads. So we fund a lead at each place, and those GPs will help support PCNs with the DES and education. As mentioned, we are scoping local enhanced schemes, looking at planning for next year. We have reviewed all of our PCN DES resources, and they can now be found on the Cancer Academy. And we're also working in collaboration with Health Education Northwest with regards to GP registrar education and training where cancer is a focus. In addition to the cancer referral documents, we are now developing templates, and these will work to sit in the GP clinical system to support clinical decision making. We have had for a number of years the Cheshire Merseyside safety netting template, which is reviewed on at least an annual basis, and this enables safety netting for cancer diagnostics and referrals and non-cancer equivalents. This template sits on the Cancer Academy and has lots of associated training and generic information about safety netting, and all of that can be downloaded from the Cancer Academy. We're also focusing on people living with HIV. This population now have normal life expectancy, but unfortunately the prevalence of cancer is higher than in the general population. So the project will seek to develop resources to improve the cancer care received by this group of people to help reduce the incidence of HPV-driven cancers in that community also. This slide summarises all the work that's happening with regards to pancreatic cancer. So we have Europac Plus, Europac Prime, and also have the UK EDI pancreatic case finding and expressions of interest from PCN project. So we need to identify PCNs in Q2 to participate in pancreatic case finding pilot, and this will start in Q3. We also have a focus on cervical screening. So we are developing a cervical screening strategy, and this will basically encompass absolutely every aspect of screening. We'll look at workforce, laboratory capacity, colposcopy, secondary care, and we'll produce a number of key recommendations to help optimise every element of the pathway. We also work very closely with NHS England and their screening improvement programmes in line with Core 20+5. And as our team expands and we have some focus on screening, we'll be able to provide some expertise and engagement to primary care looking forward. And as mentioned earlier, HPV vaccination uptake also features with catch-up. So moving on to the contracts. So with regards to QOF, this is essentially the same. There is no change for cervical screening. And similarly, there is no change for the cancer indicators. With regards to the PCN IIF, this is essentially the same, and it's looking at the percentage of lower GI urgent suspected cancer referrals accompanied by a fit result, with the results critically being recorded in the 21 days leading up to the referral. So this is worth 22 points. The lower threshold is still 65. The upper threshold is 80%. So there are some key codes listed here. A link to the dashboard, the national dashboard, which has had its own issues with delayed data and accuracy. And there's also a link then to the contract. So just a little bit of revision and focus on the lower GI suspected cancer pathway. So the documents relating to the PCN DARES make reference to NICE guidelines, but just to be reminded that we do not use NICE guidelines in Cheshire Merseyside. We use the Cheshire Merseyside pathway, which is more inclusive, with the absence of any age thresholds for adults and the addition of unexplained IDA. So please refer to information that sits both on the Cancer Academy and on the Cheshire Merseyside Cancer Alliance website. So just some key features of the pathway. As mentioned, it applies to anyone aged 18 and above. And just to focus here, the list of indications basically marry and reflect NICE, but we do have the inclusion of IDA. So this is looking at unexplained IDA or previously uninvestigated IDA in men and non-menstruating women, remembering that menstruating women with IDA need only be referred if the fit is positive. There's some very good information about IDA on the CKS NICE reference at the bottom of the slide. So just looking at IDA, there's some guidance with regards to how we should interpret our results. So you have a HB below the laboratory reference range. Clearly that makes someone anemic. If the ferritin is less than 30 or less than 24 in those listed trusts, then that person should be referred and a fit requested at the same time. Primary care do not need to wait for the results. In the green group, the patient is anemic and we check the ferritin, it's over 100 or it's over 80 in the listed trusts. And in this situation, we need to check the fit result and refer the person on if the fit is 10 or above. Regarding fit kits in primary care, fit is only indicated outside of the bowel cancer screening programme where the patient presents with symptoms of suspected lower GI cancer. We must not use the kits for screening in primary care unless specifically supplied by the screening hub. A fit request in symptomatic patients must follow an assessment through history taking and examination, otherwise you don't actually know if your patient needs a fit at all. And not all patients with suspected lower GI cancer will need a fit, and indeed clinical findings may require an immediate urgent suspected cancer referral. So this slide basically summarises fit for screening and symptomatic. So in the screening column, you can see that we are assuming that people who are being screened have no symptoms. They will be aged 60 to 74, or in Cheshire, Merseyside, with the ongoing staggered age extension, we now include people who are 54, 56 and 58. The test is offered every 2 years and the threshold for a positive screen is 120. In the symptomatic group, this includes people aged 18 and over, and it's offered when the patient presents with eligible signs and symptoms. And the threshold here is 10. So any patients presenting with symptoms of suspected colorectal cancer with a negative screening fit result, even if it was last week, must be clinically assessed and have another fit if they are eligible. So do not be falsely reassured by a negative screen fit result, because screening assumes the patient has no symptoms and a positive screening fit result is significantly higher. So when is fit required? So as long as you make sure that you have assessed your patient fully, you've taken the history and you've examined them, we then look at 3 groups. So the only patients who will never require a fit will be those with anal, rectal mass and/or anal ulceration, and they will require an immediate urgent suspected cancer referral. The middle group are patients with unexplained IDA and/or abdominal mass. They will need a fit requested at the point of referral, so we do not wait for the result. And then the third group, all of the patients with symptoms of suspected lower GI cancer will need a fit result in order to refer. However, if you're really worried and have clinical concern, or there's an issue with the fit not being returned due to patient difficulties, then you need to use your clinical judgment and that patient might still need to be referred. So please, safety net. We recommend using the Cheshire Merseyside safety netting template, which can be downloaded from the Cancer Academy. Note that the Arden's Fit template refers to NICE guidance, which could cause some confusion, so we do not recommend using it. Safety netting is necessary to ensure that the fit kit is given to the patient, it's completed, returned, and the result is managed appropriately, including a negative result. Never look at a low or negative fit in isolation, because the patient may still need to be referred urgently. They may still need a referral, may not necessarily be lower GI, it may be non-specific or otherwise. Looking at fit and coding. So practices must ensure that all of their urgent suspected cancer referrals are coded. And if you use the safety netting template, that will be supported. The reason for this being so important is that this is the denominator for the IIF. Please note that in some areas across Cheshire and Merseyside, the FIT results from the local lab does not come back to the practice with a SNOMED code attached, or it may indeed have the wrong date. So practices need to check that their FIT result has an attached SNOMED and the date is the result date, not the request date. If there is no code, this will affect your IIF target achievement. In the first instance, please contact your local IT support. There are also a couple of solutions listed on this slide, and you can also let your Cancer Alliance GP know. We have working groups for lower GI quality improvement and also a pathology group. So it's really important that you let us know. So why are there potential issues with the lab FIT date error? So this is an example of a FIT requested on January the 1st. The FIT is submitted by the patient on January the 19th. The result is issued on January the 23rd, but the date of the request is associated with the result. So actually it's labelled with January the 1st. So the GP has seen the result and the FIT test is over 10. There's a referral made on January the 23rd. Because the dates are wrong, the number of days from the results date to referral is read as 23, so it's not counted for the IIF. So moving on to the PCN DES specification, there are no service requirements this year, but basically PCNs are being asked to review cancer referral practice in collaboration with partners and making efforts to improve support of early diagnosis. And secondly, working with partners to improve screening uptake, especially regarding breast, bowel and cervical. So there are a couple of guidance areas in the contract. Just note that reporting for the PCN DES, there are no national requirements for monitoring, nor direct funding, but we would encourage PCNs to feed back to their Cancer Alliance GP so that we can pool learning and exchange ideas. So the first guidance summary is regarding improving referral practice. So this states that the PCN should work with the Cancer Alliance to increase early diagnosis and improve referral practice, that there should be a focus on colorectal and lung because these account for 40% of late stage cancers, and look at another area. Ensure compliance with NICE or locally agreed pathways. As I've just mentioned, we have the lower GI cancer pathway, which is not NICE. They recommend audits of patients with a cancer diagnosis. They recommend using fingertips, focusing on different aspects of the primary care cancer pathway, for example, the interval from first symptom to referral. They also want PCNs to promote GP direct access, which is basically focusing on patients who don't necessarily fit criteria for either an urgent suspected cancer referral or urgent cancer diagnostics. They want PCNs to promote FIT to patients with signs and symptoms of colorectal cancer. I would add where that's appropriate, and to address variation in the completion of FIT in deprived areas through education and safety netting. They also want PCNs to promote non-specific pathways and also want PCNs to promote the use of teledermatology where that is available. With regards to screening uptake, there is also some guidance. Again, they're recommending fingertips. They recommend PCNs work with public health commissioning teams. They highlight resources that are available nationally. So we've listed Cancer Research UK, who have a very good area of their website dedicated to screening. They suggest auditing non-responders to understand the reasons for low uptake, and they also advocate the use of MEC, making every contact count, which is an approach that enables screening to be checked at every opportunity. So looking at some ideas and resources. So with regards to the PCN DES, the information for this has been refreshed and is currently on the Cancer Academy, which is also going through a refresh at the moment. We also recommend Gateway C, which is very good for tumour-specific modules. So with the PCN DES, we're being asked to do two things. We're being asked to review referral practice to improve early detection with clear actions and milestones. And we're being asked to work with partners to improve screening uptake. So reviewing referral practice. What potentially makes a good referral? And there may be some other factors that you want to add in here. The first is about identifying early symptoms of cancer in the first place. It's about using the right diagnostics, referring in a timely way, referring using the agreed form and pathway to optimise triage and the potential for straight to test. It's about counselling the patient and supporting with written materials. And it's about safety netting throughout this process. So with regards to reviewing referral practice, PCNs will need to agree and plan audits to include lower GI, lung and another with clear actions and milestones. So here's an example for lower GI. So the PCN agree a plan to undertake an audit in June. The audit is undertaken to look at all urgent suspected cancer referrals for lower GI in the 3 months between September and December 2023, and the PCN are using the brief audit template on the Cancer Academy website. Key findings are then discussed at peer review in September, and those key findings reveal that people are not always using the correct form or it's incomplete, there's lack of adequate safety netting, and there are issues with some patients not returning completed fit kits. So the action plan for the PCN is that they need to ensure that the correct form is used and that it's accessible on practice clinical systems. So the refreshed Cheshire Merseyside referral forms can be found on the Cancer Academy. There is a safety netting checklist on the Cancer Alliance Academy website, and we encourage the use of the Cheshire Merseyside template, or at least something that's IT based and auditable that uses the correct fit codes. You can ensure that patients receive reminders regarding fit completion, so you could consider using Accurex. You may need to use telephone calls in some cases, or you might want to include cancer care coordinators. And the PCN has decided they're going to repeat the audit for referrals in November to January to ensure that actions have been undertaken, that the improvements have been identified, and then they are then discussed in March 2025. So the second group is lung cancer referrals. So just some notes here. 20% of people diagnosed with lung cancer are non-smokers, and those numbers are increasing. Suspected cancer symptoms in a non-smoker do need to be investigated. And note that up to a quarter of chest x-rays will be normal in people diagnosed with lung cancer. So if symptoms persist, the patient needs further investigations. And that is why safety netting in this group is very, very important. So looking at lung cancer, the plan here is that we're going to consider identifying lung cancers in non-smokers over a period of 12 months. You could use any of the audit tools on the Cancer Academy or a locally agreed audit to help explore the timely use of chest x-ray in this cohort and onward referral. You may want to attend the lung webinar on May the 14th, which is also going to be recorded to explore other possible audit ideas. Or you may want to access the lung cancer module on Gateway C, which may also help highlight areas for review. With regard to the third area, which says one other cancer type determined locally based on burden of late-stage diagnoses and opportunities for timely and effective referral to support early diagnoses, I would refer to this chart which we shared at the beginning of the webinar and focus on the tumours on the left-hand side, which we know tend to be diagnosed at a later stage. So in this example, we've decided to focus on pancreatic cancer. We're going to audit all pancreatic cancers diagnosed in 2023. We'll focus on the time to diagnosis. We'll look at any learning and develop an action plan. And we're also going to encourage clinicians to access the pancreatic cancer module on Gateway C. So we do need an action plan. So this is a summary of those 3 areas, just to give people a little bit of an idea. I would highly recommend that people get plans in place by the end of June before people disappear for the summer. So looking at screening, so we have a few highlights and ideas here. So there's the Care Coordinators Toolkit, which can be found on the Futures platform. So this includes practical ways care coordinators can work in practices to improve uptake rates in screening. It provides ideas on how to set up searches and tips on approaches to conversations. It also includes how you call for a kit. So this basically affects the practices not achieving 60% coverage, which would be highlighted through fingertips. And then they can contact the bowel cancer screening hub using the email below. Using the same kind of mechanism, reasonable adjustments can be highlighted to the bowel cancer screening hub. So, for example, if you need translated materials or if kits need to be adapted due to severe sight impairment. There is also the Cervical Screening Primary Care Toolkit and Best Practice Guide. And the presentation here from NHS England, again, which you can access via Futures. And this is about improving access and uptake of adult screening and immunisation programmes by people with learning disabilities. We also have Early Detect, Early Protect. This is a website to support healthcare and community professionals in starting conversations about screening. And there are lots of videos and posters and other resources. So, as mentioned at the beginning of this recording, we have a lung cancer webinar in a couple of weeks' time on May the 14th, which will also be recorded and will be found on the Cancer Academy. And we have the free Red Whale cancer education updates. We have a haematology webinar later in November. Details will follow. And a teen and young adult webinar in February the next year. So we have a primary care engagement team at the Cancer Alliance, which includes all of the place GPs. If you want to contact us or have any questions at all, please use the email below. Thank you for watching and listening.